Okay, so this is mechanical ventilation. We are going to be talking about monitoring. So there'll be a lot of stuff that you guys already saw. I think it's good to remember that. And in the second part, we'll talk about asynchrony. Since there are always some questions about asynchrony in your board, it's important for patient care as well. Before we talked about the ARDS, so we talked about lots of things about the ARDS, how to titrate the PEEP with different strategies, stress index. This is something I've seen questions in your board about that. Esophageal pressure guided ventilation. We'll talk a little bit more today about that. And then that was the first lecture. And this is the last lecture on mechanical ventilation. I think it will be important for you all to have one lecture on non-invasive ventilation. There are lots of new ventilators in the market now that provide different modes of ventilation. Patients are being put on these ventilators all the time. I think it's important that you guys be familiarized with these new ventilators and the new modes of ventilation. The other thing I think it will be important for you guys is to have a lecture on weaning. There's new guidelines on weaning that they were published maybe 2 or 3 years ago. It will be important for us in a lecture to review that, what the new guidelines say about weaning, what are the parameters that you have to look into when you are about to extubate a patient. So today, monitoring of respiratory mechanics, we're going to revise the main parameters to monitor respiratory mechanics, and then we're going to revise how to identify and correct asynchrony. So this is the equation of motion. The pressure applied to the respiratory system can be partitioned into the resistive pressure, so resistance times flow, plus the elastic pressure, which is tidal volume divided by compliance of the respiratory system, plus the PEEP. Okay, so there should be like a plus sign here. So we went over that. At bedside, you're going to have the total pressure, which is the peak pressure. Then you can do an inspiratory hold. You get the elastic pressure or plateau pressure. And then if you have conditions of increased resistance, this plateau pressure is going to be low, and the peak pressure is going to be high, and then the resistive pressure will be high. In conditions of low compliance, the plateau pressure will be high. So in patients with pressure control ventilation, the plateau pressure will be equal to the peak inspiratory pressure. So this is an important concept. If you are ventilating a patient on a pressure modes, so assist control pressure, the plateau pressure will be equal to the inspiratory pressure that you dial in on the ventilator plus the PEEP. Okay, so long as there's a period of zero flow, which occurs in most of the situations, you're going to have this time of zero flow. And if that's the case, the plateau pressure is going to be equal to the peak inspiratory pressure, which is going to be equal to the inspiratory pressure that you dial in on the ventilator plus the PEEP. So this is another important concept, and we talked about that during the last lecture, which is when you are measuring auto PEEP, you are probably underestimating, just because different areas in the respiratory system will have different. Some of the areas will be closed, so you're not really measuring the auto PEEP in some areas. You might be measuring the auto PEEP in areas that are partially open. Okay, so this sometimes can can lead to underestimation of the auto PEEP. Okay, some areas are closed, some airways are closed, and there's no communication with the airway opening, and therefore you're not really measuring the auto PEEP in these areas here. Okay. So you can also estimate the auto PEEP without doing expiratory hold if you have a esophageal balloon, okay? And even if the patient is spontaneously breathing, you can estimate the auto PEEP. You just look at the graphs, okay? You look at the baseline flow, how long it takes for that to go back to the zero flow here, okay? And then you can extrapolate this into the esophageal pressure here, and that will be your auto PEEP. So one of the ways that you can counterattack auto PEEP is to provide external PEEP, okay? So say you got an auto PEEP of 10, if you provide an external PEEP of 8, so the auto PEEP will be equal to 2. So this is just the formula for the mean airway pressure. The mean airway pressure is a component of for patients ventilated on volume, on peak pressure, and the inspiratory time and the total time of the respiratory cycle plus PEEP. And you can also have the same you can have a similar formula to calculate, to measure the mean airway pressure in patients being ventilated on pressure modes, which is a similar formula, peak minus PEEP, and then you have the total time of the respiratory cycle and the inspiratory time plus PEEP. This is a concept we talked during ARDS, and we just did that at bedside. So when you are ventilating a patient on assist control volume, you can actually get an estimate of the stress index, which is this coefficient B here. Okay, so what you want to do is put a patient on flow modes, like volume modes, low flow, like 10 liters per minute, and then you look at this pressure time curve, and if it is concave up, it means that over time your pressure is increasing exponentially, and therefore you're getting overdistension. So concave up, typically this coefficient here will be more than 1. Okay, so the stress index will be more than 1, and you're getting overdistension. If you are concave down, it means that the stress index here is less than 1, and there's room for recruitment. If it is linear like this, it means that you are not overdistending, but there is also not a lot of room for recruitment. So this is just showing here. So here a patient has a stress index of 0.75, so you see that it's concave down, so there's room for recruitment. Here it's pretty, there's no overdistension, no room for recruitment. The stress index is around 1. Here it's concave up, the stress index is 1.38. You see that the airway pressure is increasing exponentially over time. Okay. So the other important monitoring aspect of respiratory mechanics is the esophageal pressure. We have been doing mostly at Jewish. I don't think we have the equipment here at the university to get an esophageal pressure measurement. So the esophageal pressure is a surrogate for the pleural pressure. Okay. So just showing how if someone is spontaneously breathing, the pleural pressure can be around -5, -8, okay? And the transpulmonary pressure, which is the plateau pressure minus the pleural pressure, can be +8 here, for instance. On someone who is mechanically ventilated, you can have esophageal pressure that is pretty high, like 25, and therefore the pressure is all being dissipated into the chest wall, and the transpulmonary pressure, which is the pressure that you get more worried because it's the pressure that can cause harm to the lungs, can be not that high. For instance, here the transpulmonary pressure will be the plateau pressure, which is 30, minus the esophageal pressure, which is 25, so not too bad, 5. Okay, so if someone is playing the trumpet, so the esophageal pressure can be super high. Even though the alveolar pressure is high, they don't develop pneumothorax because a lot of that is being dissipated into the chest wall, and the transpulmonary pressure can be the transpulmonary pressure can be not that high. So that's good. So one of the things we need to be mindful is that if a patient has ARDS, and you put that patient in spontaneous mode. There are some studies that have looked at spontaneous modes for ARDS. Patients tend to be more synchronous with the ventilator when you put a patient on pressure support, for instance, even in ARDS. The problem is that these patients can generate a very negative esophageal pressure. So be cautious because, you know, the transpulmonary pressure here can be pretty high. So be cautious about ventilating a patient with ARDS on pressure support because, like I said, the esophageal pressure can be very negative, and therefore the transpulmonary pressure can be very high in the end of inspiration. So here we're talking about transpulmonary pressure in the end of inspiration, okay guys? So the pressure to overcome the recoil of the respiratory system, okay, can also be equal to the elastance of the lung plus the elastance of the chest wall, okay? And the elastance of the chest wall varies from patient to patient. So elastance is the inverse of compliance. So here's showing esophageal balloon. Okay, typically you put the balloon. Sometimes the esophageal catheter will have two balloons. One in the gastric, one will be the gastric balloon, and another one will be the esophageal balloon. But a lot of times it's kind of hard to make sure that the balloon is in the right place. Okay, so there are some techniques that you can use to make sure that the esophageal balloon is where you want it to be, as opposed to in the gastric area. So one way is if the patient is spontaneously breathing, you do a expiratory hold. Okay, with the expiratory holds, you're gonna have as the patient is doing an effort to breathe, your esophageal pressure is gonna go down. Okay, and your airway pressure is going to go down, your esophageal pressure is going to go down, but the transpulmonar pressure is going to stay the same because the volume doesn't change. So this is an important maneuver that you guys may want to do if the patient is spontaneously breathing. Okay, just do an expiratory hold, take a look at the airway pressure, take a look at the esophageal pressure. They should vary equally, but the transpulmonar pressure shouldn't change. If the patient is not spontaneously breathing, you can push the belly. Okay, that's another maneuver that you can do. Okay, so you're gonna have an increase in the airway pressure, an increase in the esophageal pressure as well. Okay, but the transpulmonar pressure will be about the same. So two maneuvers that you guys wanna do once you place a esophageal catheter for measuring of the esophageal pressure. So another important concept that measurement that you can get with the esophageal balloon is the transpulmonar pressure at the end of expiration. So we'll talk about the transpulmonar pressure in the end of inspiration before. Now we're going to be talking about transpulmonar pressure in the end of expiration. So the transpulmonar pressure in the end of inspiration, you want that to be less than 25. And that is the pressure that is associated with lung injury, okay? So you want the transpulmonar pressure in the end of inspiration to be less than 25. So plateau minus esophageal pressure less than 25 is what you're going to be targeting, okay? But the transpulmonar pressure at the end of expiration, you want that to be positive, okay? Because if it is negative, it means that the patient is developing a teletrauma in the end of expiration. So the transpulmonar pressure in the end of expiration is the total PEEP minus the esophageal pressure in the end of expiration, okay? So PEEP applied on alveoli needs to overcome the pleural pressure to achieve a recruitment. So if this pressure here is negative, it means that you are getting a teletrauma, okay? So this is important because, you know, this clinical trial here, we talked about this trial many times, right? This clinical trial, they used the esophageal balloon to titrate the PEEP in one group. In another group, they used the PEEP FiO2 table. So, so this is how they titrated the esophageal pressure guided group. Notice that they are looking at the transpulmonar pressure in the end of expiration. And the higher the FiO2 that you are requiring, the higher the transpulmonar pressure in the end of expiration they wanted the patient to be. Okay? So that's how they titrated the PEEP on these patients. Remember that the transpulmonar pressure in the end of expiration is PEEP minus esophageal pressure. On the other hand, you have the FiO2 PEEP table here, which we're used to, right? So here, this is what happened on this small clinical trial, okay? So a lot of patients who are on the esophageal pressure group, they had to actually increase the PEEP. So for most patients who are ventilated, according to this trial, the patients are actually developing a teletrauma, okay? Particularly if you use the PEEP FiO2 table, okay? So notice that in the group that they use the PEEP FiO2 table, in a lot of patients, they actually decrease the PEEP, okay? So what this study is telling us is that we are maybe underutilizing PEEP even if you use the PEEP FiO2 table, okay? But every patient is different, so you gotta tailor, you know, the PEEP to the patient that you're managing, okay? Another way of titrating the PEEP that we're using more and more is using the driving pressure, which is the plateau minus PEEP. So basically, what you do is, okay, I'm ventilating this patient, I'm gonna measure the driving pressure, I'll go up in the PEEP, and then I'll measure the driving pressure again. If my driving pressure is going up, it means that I'm probably causing overdistension. I'm not going to go up in the PEEP. If my driving pressure is going down, I'm recruiting the lung. Okay, so we're using the driving pressure to titrate the PEEP. So transpulmonar pressure in the end of inspiration, we already talked about that, plateau minus esophageal pressure in the end of inspiration. This is just an example. I think we talked about that in the past. So say you got a so you're having this patient here, the end expiratory esophageal pressure is 26, the PEEP is, I believe, 16 here, so my end expiratory transpulmonar pressure is -8, so, and the transpulmonar pressure in the end of inspiration here is 27, the plateau is 26, so the transpulmonar pressure in the end of inspiration is 1. So this patient obviously has a lot of, is developing atelectrauma, so you want to go up in the PEEP maybe in a patient like this, okay? So another case here, the esophageal pressure in the end of expiration is 26, the PEEP is 26, so the transpulmonar pressure in the end of expiration is 0. The transpulmonar pressure in the end of inspiration, so you get the plateau pressure here, which is 40, and the esophageal pressure in the end of inspiration is 30. So this patient is not really developing atelectrauma and not really developing overdistension. So one of the things that you want to always monitor is the compliance of the respiratory system. So conditions that cause decreased compliance include ARDS, pneumonia, bilateral pleural effusion, abdominal distension. So if you're ventilating a patient with ARDS, every day you want to assess the compliance of the respiratory system, which is tidal volume divided by plateau minus PEEP, and the normal range goes from 50 to 100. Compliance of the chest wall is a concept that you can get so long as you have esophageal balloon, okay? And conditions that cause decreased compliance of the chest wall include obesity and edema, okay? So those are the main conditions that cause decreased compliance of the chest wall, or if you have abdominal distension as well. So it's tidal volume divided by esophageal pressure in the end of inspiration minus esophageal pressure in the end of expiration. So the normal chest wall compliance is 80. So here is just showing you tidal volume 320 and how you can get the compliance of the chest wall. Lung compliance is the tidal volume divided by the difference in the transpulmonar pressure in the end of inspiration and end of expiration. So the normal lung compliance is 200 ml per centimeter of water. So you get your tidal volume and your transpulmonar pressure in the end of inspiration and transpulmonar pressure in the end of expiration. So the elastance is the inverse of the compliance. So the elastance of the respiratory system is equal to the elastance of the chest wall plus the elastance of the lung, okay? So this is another concept. So airway resistance is something that you can easily calculate at bedside as well. Basically, it's the peak pressure minus the plateau pressure divided by flow. So again, peak pressure minus the plateau pressure divided by flow. You can get the airway resistance. Work of breathing is something that we don't do very often, but it's important that you guys know the concept. We don't measure the work of breathing at bedside very often, but some of the new ventilations, new modes, they can actually measure the work of breathing non-invasively. Proportional assisted ventilation will actually provide you the work of breathing with some algorithms that they used. But classically, the work of breathing, to measure the work of breathing, you need an esophageal balloon, okay? So the driving pressure can be generated in three ways, entirely by the ventilator. So the patient, when the patient is passive on controlled mechanical ventilation, entirely by the patient's respiratory muscles, spontaneous and assisted breathing, a combination of two. So how can you calculate the part of work of breathing generated by the patient? So you get the pleural pressure, which is the surrogate of the esophageal pressure, and you measure the esophageal pressure during patient effort and esophageal pressure during passive ventilation. And then with that, you can kind of see how much of work of breathing the patient is doing. So work of breathing is expressed in joules. Okay, 1 joule is energy needed to move 1 liter of gas through a 10 centimeter of water pressure gradient. So this is the Campbell diagram that some softwares will provide to you. I never saw that. I don't know if at Jewish they have that available. But basically, this is a graph where they can partition the work of breathing that the patient is generating into resistive work of breathing, elastic work of breathing, and if there is auto PEEP, the work of breathing to overcome the auto PEEP as well. So this is, if you have an esophageal balloon, if you have the software, you can actually obtain this graph, and you can kind of partition the work of breathing the patient is doing. So we talked about that. So this is just to demonstrate how the presence of auto PEEP can significantly increase the work of breathing for patients who are trying to generate a breath. Let's say you have a patient who's having a tidal volume of 500 and a pressure gradient of 7. The work of breathing will be 0.5 times 7, so 0.35 joules per cycle. Now let's say this patient has auto PEEP of 5. And in order for the patient to initiate a breath, the patient has to overcome this auto PEEP of 5. So suddenly your pressure gradient goes up from 7 to 12, and the work of breathing increases 40%. So be mindful that in a patient who is trying to initiate the breath and you're having auto PEEP, the work of breathing can be significantly increased. So this is important in patients with COPD or asthma, or even in ARDS patients. Carbon dioxide monitoring is something that we're doing all the time now, okay? So basically the PaCO2 that you get in the blood is a function of the production of VCO2 by the body, right? And the alveolar ventilation, which is the minute ventilation minus the dead space. And the dead space is the reason why some patients will have a very high minute ventilation and yet the PCO2 is high, because they have very high dead space. Okay, so that is when you are ventilating a patient and the PCO2 is high despite a high minute ventilation, oftentimes it's because the dead space is very high. So how can you carbon dioxide monitoring? You can do that through capnography. So capnography is the non-invasive measurement of carbon dioxide in exhale breath, and capnogram is the waveform that you get. Okay. So there are different monitors for carbon dioxide monitoring. There is a mainstream monitor, which is a sensor located on the airway adapter at the hub of the endotracheal tube. This is for patients who are intubated. And there are side stream devices that we have been using every once in a while for patients undergoing conscious sedation. Even in the bronch suite, we have used that. So you can do that with a nasal-oral cannula. So the carbon dioxide monitoring can be quantitative, that's capnometry, or number and waveform, that's capnography, okay? It can be also qualitative, so arranging the entitled CO2. So colorimetric entitled CO2 detector is the classic example when we're intubating patients. So it'll be purple if the entitled CO2 is less than 3, 10 if 3 to 15, and yellow more than 15. So you use that every day when you're intubating patients. Now, it's the gold standard, by the way. When you guys intubate patients, the gold standard is really visualizing the endotracheal tube going through the vocal cords. But short of that, entitled CO2 should be your gold standard to decide whether the tube is in the right place or not. And then you do auscultation and other things. So this is the graph, how it looks like. So phase 1 is the gas from the apparatus and atomic dead space. Phase 2 is the increasing CO2 concentration from alveolar emptying. And phase 3 is alveolar gas. So we are using that to monitor the ventilation of patients, and actually this has become standard of care. I think all the patients now being ventilated have entitled CO2 where we can monitor that. We can also use that to monitor the quality of your cardiopulmonary resuscitation, and so on and so forth. Okay, so now we're going to go to the second part of this lecture, which is asynchrony. Okay, so basically, there are different ways the researchers have classified asynchrony. Okay, I'm using the classification by Dr. McIntyre because I think he is the one who actually writes the questions for the boards for you guys. Okay, so I got a lot of articles from him, and some other folks have been working on asynchrony, but I'm using his classification here. So he classifies asynchrony into trigger asynchrony, flow asynchrony, and cycle asynchrony. Okay, so trigger asynchrony, flow asynchrony, and cycle asynchrony. So trigger asynchrony is difficulty triggering the ventilator, is one of the trigger asynchronous that you can get, or when the ventilator auto triggers. Flow asynchrony is when the ventilator does not meet the patient's inspiratory flow demand, and cycle asynchrony is when the neuroinspiratory time does not match the inspiratory time set on the ventilator. So before we go over the asynchronies, how to recognize, just a little epidemiology here of the asynchrony. So there's something called the asynchrony index. You're going to see that a lot in the literature. Okay, so the asynchrony index is the number of asynchrony events divided by the total respiratory rate times 100. So patients in the ICU usually have a median asynchrony index of 2.1%. Okay. However, 25% of the patients can have a asynchrony index more than 10%. And this is based on this study here, if you guys want to take a look at. Ineffective triggering in different studies has been shown to be the most common asynchrony, okay? So represented 63% of all asynchronous in one series, okay? In another series, it represented 85% of the asynchronous, ineffective triggering. And then double triggering represented 13%, and then you have all the asynchronous here that represent less than 1%. So what are the consequences of having asynchrony? Why is that important? So it can lead to those physiologic changes here. So increased work of breathing, air trapping, respiratory alkalosis. You may need to increase sedation, and it can also disturb the sleep of our patients in the ICU. But really, I mean, does it really matter? What about clinical outcomes? Does it matter? It appears that it does, although there isn't a lot of studies on that, okay? But this investigator here has been doing a lot of interesting studies on asynchrony, and he has this study in intensive care medicine from 2015. He actually developed a software that analyzes more than 7,000 hours of mechanical ventilation in this particular study. And interestingly, asynchrony are less frequent between 12 p.m. and 6 a.m. I guess when the ICU is more quiet and patients may be sleeping. Patients with asynchrony index more than 10% had similar reintubation rates, similar tracheostomy rates, a trend toward longer duration of mechanical ventilation, but higher ICU hospital mortality. So it looks like he demonstrated that asynchrony is associated with increased ICU and hospital mortality. 50 patients, very small study. Whether this is true or not, I'm not sure, but it makes sense. So let's start off with trigger asynchrony. So what is the asynchrony pointed out by the arrows in the figure below? So this is a question for the fellows here. It's a little difficult to read. Yeah, so it's in effect. Why do you say it's ineffective triggering below?
The waveform goes down.
Goes down. So this is an important concept. Every time the patient is making an inspiratory effort, the pressure waveform is going to go down. Knowing that, you can maybe kind of solve a lot of asynchronous. So every time the patient is doing inspiratory effort, the airway pressure is going down. So the airway pressure is going down here. So this is before, and then you have this effort that is not followed by a tidal volume. So this is ineffective triggering. So again, inability to trigger the ventilator or ineffective triggering. So the arrow indicates missed effort, which are characterized by expiratory flow reversal on the flow time tracing and transient pressure reduction on the pressure time tracing. Transient pressure reduction. This is very important. So this is another example of inability to trigger the ventilator. Okay, so this is the transient pressure reduction here. And the flow, I think this arrow is probably should be here. The flow should actually go up a little bit, but the airway pressure is going to go down. So what type of asynchrony is shown here? Auto-cycling, delayed trigger, or premature cycling of patient-triggered breath. Okay, so see, so here it can get a little confusing. Okay, this is a trigger asynchrony, even though the problem is really, again, I'm using Dr. McIntyre's classification, okay? So he classifies this as a trigger asynchrony, but the problem really is a flow problem. You know, it's not really a problem. There's no problem with the sensitivity of the ventilator. It's really a flow problem, okay? So again, this is a premature cycling of patient-triggered breath. Okay, so the nomenclature is a bit confusing here, in my opinion. Okay, this is also called double triggering or stacked breath. So there's no valve sensitivity problem here. Okay, so the patient effort exceeds the volume of the flow settings on the ventilator, and the patient is doing such an effort that the airway pressure goes down to the extent that it triggers the ventilator. Okay, again. So the patient effort exceeds the volume of flow setting on the ventilator. The continual effort causes the air pressure to drop below the trigger threshold. Okay, so this is a trigger asynchrony, but really there isn't much of a problem of triggering here. So again, just to summarize, so inability to trigger the ventilator. Okay, so why could this happen? Well, once Bilal and I were called to assess a patient at Kindred, and when we got there, the patient was literally, he was like that, and he was it was the most uncomfortable patient we ever saw. Is that correct, Bilal? And nobody knew what was going on with that patient. He was unable, and when we saw he was not getting volume, we thought, wow, is there a problem of the machine? What's going on? And then we decided, let's take a look at the sensitivity. Well, it was not being displayed on the. It was kind of a weird ventilation. The sensitivity was not being displayed, and I think the sensitivity was set at what? Negative 20, right? So we've been called that patient. When we saw him, he had been like that for maybe a couple of hours, right? So yeah, so the trigger sense setting. I mean, obviously there was a extreme case, but. If you say, oh, I'm gonna put the flow of -5 or pressure of -5, so the patient can trigger the ventilator, that might be too much. Okay, so insensitive trigger setting on the ventilator. So you can have inability to trigger the ventilator if you have muscle weakness. Okay, so in situations like that, you just reduce the pressure flow required to trigger the ventilator. If you have auto PEEP, then you need to increase the expiratory time. And what is the most effective way of increasing the expiratory time? Decrease the respiratory rate, okay? Auto-triggering, I think I was with you at Jewish when a patient who had a pacemaker, right? Yeah. And every time the pace would pace, he had a breath from the ventilator, right? Yeah. That was quite interesting. But cardiac oscillations themselves can cause the ventilator to trigger. That's why I'm always cautious to, like when I'm assessing a patient for brain death, you know, don't take at face value that patient is actually taking a breath. If you see assisted breath on the ventilator, like every once in a while, that might be triggered by cardiac oscillation, okay? Excessive water condensation in the ventilator circuit can cause auto-triggering leaks in the circuit. So you need to fix those things, right? You gotta drain the circuit, you gotta correct the leak here. So this is a case again of inability to trigger the ventilator, transient pressure reduction. This is auto-triggering. This is how it's gonna look like. So now we're gonna talk about flow asynchrony. So what type of asynchrony ventilator patient asynchrony is found below? Inadequate flow, yeah, okay. So the patient is actively trying to inspire while the patient is receiving the volume or the pressure, and therefore there is an airway pressure going down here, okay? A reduction in the airway pressure. So this is inadequate flow. Inadequate flow is characterized by excessive patient effort. And the hallmark in pressure time tracing is that the airway pressure is sucked down during inspiration. So airway pressure is going to go down because the patient is doing an inspiratory effort. So this is a patient of asthma exacerbation. What type of asynchrony does this patient have? Is the same, okay? Flow asynchrony. Again, this is another case of flow asynchrony in which the set flow is not meeting the patient's demand in the context of asthma exacerbation. This is indicated by the pressure curve, which is convex downward. So when you have inadequate flow, that can be caused by excessive effort during breath. The airway pressure is going to be sucked down, like I said. It can be caused by inadequate tidal volume with preset target, with pressure target breaths. So it can cause inadequate tidal volume, with pressure target breaths. So what do you want to do? You want to increase the flow. Sometimes if you change to a pressure mode, it helps if the patient is being ventilated on volume. Or if the patient is being ventilated on pressure, you might want to increase the pressure setting. Excessive flow, there will be expiratory efforts to terminate breaths. Higher tidal volume with pressure target breaths. So you want to decrease the flow in flow target mode or decrease inspiratory pressure in pressure target mode. So again, this is how it's going to look like inadequate flow. This is just different examples of inadequate flow. I think you may end up getting very similar graphs in your board. Okay, so the airway pressure is sucked down. What about psychoasynchrony? What is the asynchrony below? What is happening to the airway pressure here?
It goes more negative.
It goes down. So what is the patient trying to do? The patient is trying to continue to inspire, right? While the machine already cycle. Okay. So what is that then? Yeah, premature termination. The machine inspiratory time is lower than the patient's inspiratory time. The patient's continual inspiratory effort pulls down the airway pressure and reverses the expiratory flow in the end of exhalation.
Dr. Kat, could you also call that ineffective trigger, asynchrony as well?
Well, it's happening the end of that's the key thing. It's happening the end of the inspiratory cycle. In the end, yeah, I think you could, but I think, so you can kind of put in the classification that Dr. McIntyre likes to use and that you're probably going to have in your board. The key thing is that it's happening the end of the inspiratory cycle. So this is a patient press support ventilation. What is the asynchrony here? So when the patient is inspiring, the airway pressure should go down. If the patient is trying to exhale, the airway pressure is going to go up, right? So is it inadequate flow, delayed termination, or excessive flow? Delayed termination. So the patient's neural time precedes the end of the mechanical inflation, which results in a pressure spike. So this is another example here, okay? Back to back. So neural inspiratory time, longer than machine inspiratory time. Effort continues despite breath termination. Airway pressure is sucked down and can trigger second breath. So what you want to do, you want to lengthen the cycle criteria. Machine inspiratory time, longer than neural inspiratory time. So there's going to be an expiratory effort from the patient to terminate the breath, and there's going to be a spike in the pressure. So you want to shorten the cycle criteria. So again, here neural inspiratory time, longer than machine inspiratory time. So the patient is trying to continue the inspiration, so the airway pressure is being pulled down, the flow is being pulled up. So machine inspiratory time, longer than neural inspiratory time. So the patient is trying to terminate the breath, so the patient is trying to exhale, so there's a spike in the pressure here. Thank you.